Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Catherine Coombs from UCI Health and Dr. Toby Eyre from Oxford. They will be discussing their choices of key studies presented at the recent SOHO 2023 annual meeting, focusing on the use of BTK inhibitors in chronic lymphocytic leukemia and mantle cell lymphoma. This episode is part of a larger educational program titled Targeted Therapeutics in CLL and MCL, applying emerging BTK inhibitor therapy data to practice. For more information on the experts, along with a link to the complete program, including a downloadable slide set and expert discussion, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi there, I'm Dr. Catherine Coombs, presenting on behalf of Clinical Care Options some of the research that was presented at the SOHO meeting in 2023. It's a pleasure to be here today with my colleague, Dr. Eyre.
Yeah, hello everybody. Great to have you with us. I'm Toby Eyre. I'm a consultant hematologist in Oxford in the UK. And I'm going to be starting off by asking Callie some questions around some of the CLL abstracts that we saw at the Congress. So the first one that we've picked is a matched adjusted indirect comparison of 3 randomized phase 3 trials, which all included ibrutinib as one of the control arms. So as I'm sure many people are aware, we've seen important randomized trials recently, the Alpine trial of ibrutinib versus zanubrutinib and the Elevate-RR study of ibrutinib versus acalabrutinib with some slightly different results, interesting results. And this is an attempt potentially, Callie, to look at the control arms and how the control arms performed in this study. I wonder if you had any thoughts about this comparison.
So I actually thought this was an interesting study, an interesting question to ask, which is essentially how has ibrutinib performed over time in all of the different randomized studies that used in the relapse setting. And so just as you mentioned, the idea was to do these match-adjusted indirect comparison of 3 different randomized phase 3 trials where ibrutinib was used in one of the 2 arms. So these 3 studies were Resonate, Alpine, and Elevate-RR, as you mentioned. And as we know, the dogma in medicine is you should not do cross-trial comparisons, yet we are all doing them. And I'd say it's even more common nowadays. And so I think these analyses are thought-provoking, but of course the gold standard is always a prospective randomized trial where the groups are truly balanced. When these matched-adjusted indirect comparisons are done, the groups are inherently different. And so they make a statistical attempt to match the baseline characteristics. And so that was done as part of this analysis to assess how is ibrutinib performing in these different studies. And so this is a way to equalize the playing field, but of course it is an imperfect exercise. Nonetheless, they matched patients based on a number of important clinical features such as age, presence of bulky disease, how many prior treatments they had, and their cytogenetic markers to come up with a Resonate adjusted population to then compare to either Alpine, the phase 3 study using zanubrutinib, or Elevate-RR, the phase 3 study using acalabrutinib. And so what they found is that when they looked at these Resonate adjusted populations, the overall response rate ended up being numerically higher for both of the Resonate adjusted populations compared to Alpine and Elevate-RR respectively. And this did reach statistical significance, though to a greater effect when comparing against Alpine. Next, they looked at the progression-free survival rate. And I think this is particularly interesting. After Alpine came out, there was a lot of comments about, gosh, did ibrutinib underperform in this study? And so in this match-adjusted analysis, looking at ibrutinib, it did show that when comparing the Resonate-adjusted population, their median progression-free survival was higher than patients in Alpine. So this was 40.7 months compared to Alpine's 34.2 months. However, when comparing the Resonate-adjusted population to Elevate-RR, there was no statistical difference in these progression-free survivals. So suggesting perhaps Alpine did have an underperformance of ibrutinib in the control population. Now, what am I going to take from this study as far as my clinical practice? Well, this isn't going to outweigh the findings of Alpine, which in my view was a positive study. Zanubrutinib did outperform ibrutinib. However, I think what it does reflect is how control arms can perform over time and how I think about ibrutinib control arms in the future. So I think that with subsequent years in our history of CLL, I think it's not unexpected to see a change in the progression-free survival of ibrutinib because the eras are very different. So RESONATE, being the oldest study, really reflects a population of CLL patients that had few, if any, good options. And so I think their motivation to stay on therapy is absolutely the highest. Now, as time goes on, our options for alternative therapies for our patients continue to change. And so I think when a patient has a lot of options, perhaps their motivation to stay on a therapy in the setting of a toxicity becomes a little bit lower because they have more available for them in that setting. And so I think it's an interesting study, not practice changing, but certainly somewhat thought provoking, and will be something I think about with further studies using ibrutinib as a control arm with respect to its performance.
Yeah, absolutely. Thank you, Callie, for a very clear overview there. I very much concur with the sort of change over time and clinician and patient preference and the way studies may be managed now. Of course, we very rarely get to see the sort of post-protocol care data in huge granularity. So certainly that'll be something I'll be keeping my eye out for when we hopefully see longer follow-up in Alpine. How many of these patients did ultimately stop and switch to a second-generation BTK inhibitor like, for example, acalabrutinib outside of clinical studies, and was there sort of global disparities there? It'd be very interesting to see. Hopefully we will see that in time. We'll have to watch this space. Thank you. And then the second abstract that we've picked out is a meta-analysis of cardiovascular adverse events with some of the second-generation BTK inhibitors. Now, of course, we are spoiled for choice now with BTK inhibitors, and so we scrutinize small differences in BTK inhibitor rates of toxicities, and certainly cardiovascular adverse events such as atrial fibrillation are, as you know, Callie, scrutinized very carefully across these studies. And this is a systematic review and a meta-analysis of second-generation BTK inhibitors. I wonder if you could talk me through some of the key findings in this analysis.
Yeah, so the investigators in this study took a look at all the randomized phase 2-3 studies of acalabrutinib and zanubrutinib in CLL and came up with 5 trials that met their eligibility for their meta-analysis to really try to understand how are these newer generation BTK inhibitors performing with respect to some of the key toxicities that we worry about, which include cardiovascular adverse events, and then, of course, bleeding risk being factors that we consider when we're using these drugs. So what they did is they lumped all of these eligible studies together to assess how they're performing with respect to toxicity profiles in comparison to the control arms, which were different in these studies, of course. What they found is that there was, in fact, a significant reduction in cardiovascular mortality with an odds ratio of 0.16, favoring the safety profile of these new drugs to their comparators, with a lower rate of cardiovascular AEs leading to death when using acalabrutinib and zanubrutinib in this pooled analysis. However, we do note that these drugs do lead to significant bleeding events. And so on that meta-analysis aspect, they did find a significantly higher risk of bleeding in the patients that were enrolled to the treatment-naive studies with an odds ratio of a little over 6. This was any bleeding. And so they also similarly found a higher risk of major bleeding, once again, in this treatment-naive CLL population with an odds ratio of 2.8. So I do think it is an interesting study to kind of pull together the data that we have from our second generation, if you will, BTK inhibitors, acalabrutinib and zanubrutinib, once again showing that they are a better tolerated class and certainly pose an advantage over the predecessor comparator arms from these pooled studies. But it is important to keep in mind this bleeding risk, which in my view, in my own practice, is pretty similar among all of our available covalent BTK inhibitors, and certainly is a class effect, in my opinion, that one needs to watch out for when using these drugs.
Yeah, absolutely. Certainly an interesting observational study, as you say, probably unlikely to change sort of practice in what we do. I do wonder, maybe I need to take a deeper look at this data, but I do wonder whether there may be an effect of just cumulative events occurring in patients receiving a BTK in the frontline setting compared to relapsed refractory disease, where we know patients will be on a BTK inhibitor for a shorter period of time. So I wonder if an adjustment needs to be made for the time on therapy, because to my mind, that's an important part of an analysis such as this. But certainly intriguing and thought-provoking data.
Yeah, I think that's a good point. And with any study of BTK inhibitors, you always have to really read into the data to understand, are the reporting periods equal if they're being compared to something time limited, such as, bendamustine rituximab or, whatever, depending on what study was looked at in this meta-analysis. And so that type of granularity wasn't clear to me from the abstract, but if this ends up getting published, maybe that'll be a bit more clear. So that's a great point. So now let's pivot into talking about a couple of the mantle cell lymphoma abstracts that we have picked out. And so the first study that we'd like to discuss is the BRUIN trial. And so at our summer congresses, including SOHO, we have seen some updated results from this pirtobrutinib in mantle cell lymphoma. So I was hoping that you could touch upon this, Toby.
Yeah, sure. Thanks, Callie. So for listeners who haven't heard much about pirtobrutinib, this is a pretty new non-covalent reversible BTK inhibitor, highly selective BTK inhibitor with a very favorable pharmacokinetic profile, which is being developed across a range of B-cell malignancies in the BRUIN trial. And we've actually seen pivotal data now from the BRUIN trial assessing a total of 166 patients with mantle cell lymphoma, and the primary analysis set of 90 patients has been presented and actually published in the JCO earlier this year. And this takes a high-risk group of patients with mantle cell lymphoma, nearly all exposed to chemotherapy, CD20 antibody, and all exposed to a prior covalent BTK inhibitor, and looks to assess the response rate and a number of other important endpoints such as survival and toxicity. This formed a subgroup of the BRUIN trial, which, as I say, assessed a number of B-cell malignancies and was a large phase 1-2 study. No maximum tolerated dose was found in the phase 1-2 study, and 200 milligrams once a day was used as a recommended phase 2 dose, and most patients have received that dose. And when you take a deep dive into the baseline characteristics, you'll see that these patients, as mentioned, are heavily pretreated, the majority stopping the prior covalent BTK inhibitor for progressive disease across the patients that have had a prior covalent BTK inhibitor. There was a small BTK naive subcohort with an eye to the future, looking to see how active this agent is in covalent BTK naive relapsed mantle cell lymphoma. And the response rate in that small subgroup was high at 85.7%. Now, the longer-term follow-up, which is what we've seen from the recent abstract, showed that the overall response rate was 56.7% in this group of patients, with a CR rate just under 20%, and a good number of patients developing tumour responses, including patients with higher risk disease, which was one of the aims of this abstract. The duration of response overall was 17.5 months, and the PFS 7.4 months. So interesting that if patients did respond, which is obviously just over half of patients, you had really quite durable responses given this clinical context. And the overall survival, the median, has been reached at just under 2 years, which, when you compare to how patients performed historically following covalent BTK inhibitor failure, this seems to be certainly a step in the right direction. One of the interesting sub-analysis that was presented here was duration of response by higher risk features, so high Ki-67, TP53. Now, one of the problems with this study was that there are really quite small numbers being assessed here, and clearly more data needs to be collated from these patients in the study, and hopefully they will be in time. But in these small subgroups, you saw no real difference in terms of duration of response according to those higher risk groups. So at least suggestive that pirtobrutinib may be as active in patients with, for example, a TP53 mutation. But I think we certainly need more data before that's certainly shored up. Then just finally, we saw longer-term safety data. We've just been talking about safety data with covalent BTK inhibitors. The safety data with pirtobrutinib looks excellent to date. Relatively short follow-up overall, but what we do know is that the rates of discontinuation due to adverse events is very low, at between 2 and 3%, 3% in the mantle cell cohort, and the rates of grade 3 toxicities are really very minimal.
Well, thank you for that overview. And so I'm, of course, interested to see what comes of the phase 3 study in mantle cell lymphoma, where pirtobrutinib will be compared to investigator choice of covalent BTKI, ibrutinib, calibrutinib, or zanubrutinib. What are your thoughts on this study, and what would you expect with respect to, I think that the responses look very promising in the BTK naive mantle cell patients.
Yeah, absolutely. So this is a phase 3 superiority study of 500 patients in relapsed mantle cell lymphoma. So I suppose innately a fairly brave study, and also comparing against the de facto standard of care. So in Europe, people use ibrutinib. It's approved by the EMA and the MHRA. And in America, obviously, there's been much publicized change recently, but second generation BTK inhibitors is very much to the fore there. So zanubrutinib and acalabrutinib. So they're very much a standard of care option in relapsed mantle cell lymphoma. And as mentioned, this is a superiority design. I suppose the idea here is that rates of discontinuation due to toxicity will be very low with pirtobrutinib. The reversible nature of the BTK inhibitor and the PK profile with the IC90 being exceeded across the whole 24-hour period should lend itself well to be particularly active in more proliferative diseases. And we've certainly seen data in mantle cell lymphoma and Richter's. It looks very active as a monotherapy. So yeah, I mean, watch this space. The study's recruiting well, and we'll have not only head-to-head data from an efficacy standpoint, but I think also some very intriguing head-to-head data from a toxicity standpoint, which may have sort of broader ramifications, perhaps beyond just mantle cell lymphoma. So an important study for a number of reasons, I think.
Yeah, all right. Well, the last study that we were going to speak about is this ViPOR trial combining venetoclax, ibrutinib, prednisone, obinutuzumab, and lenalidomide in patients with relapsed refractory and treatment-naive MCL. So could you touch upon the findings that we've seen from this study, please?
Yeah, thanks, Callie. Thanks for pronouncing the study and naming all the drugs. You sort of saved me that. This is an intriguing study, certainly. This is a study sort of designed in the NCI, and they have tested this combination ViPOR in a range of malignancies, particularly DLBCL, but now we're seeing some data in mantle cell lymphoma. So this is a phase 1-2 study, a 3+3 design, looking at dose escalation cohorts of venetoclax with fixed doses of ibrutinib, the steroids, the obinutuzumab, and the lenalidomide. And then we'll see a little bit more data with expansion cohorts in relapsed refractory and indeed treatment-naive mantle cell lymphoma. Now, actually, when you look into the data, into the literature, certainly venetoclax, ibrutinib, lenalidomide, all clearly active drugs in mantle cell lymphoma. There have been some challenges combining IMiDs and BTK inhibitors in the past in terms of toxicity, so one must be wary about this. And of course, this has a potentially substantial financial toxicity associated with it, which of course is a major consideration when you look at a regime such as this. There's 26 patients treated so far, 12 in the relapsed refractory setting, 14 in the frontline setting, and there are some high-risk patients seen in this study. And toxicity was manageable. The main toxicities were hematological, as one might expect, but grade 3 or greater cytopenias were relatively manageable. In terms of non-hematological toxicities, the rates of atrial fibrillation were 8%, the rates of rash 12%, this is grade 3 or greater, with some infections and small numbers of other toxicities seen. And dose reductions were required in about a quarter of patients, and most of those related to lenalidomide and were related to cytopenias, as one might expect, with 86% completing 6 cycles. So this is a manageable regime to deliver in trial-fit patients, and does have the advantage of being fixed duration therapy. When the efficacy is analysed, all patients responded. The CR rate in those who were efficacy evaluable was 100%, which is impressive. And this included patients with blastoid disease, TP53 mutation, etc. And outcomes seem to be durable to date, although longer follow-up is certainly needed. MRD was also assessed as a sub-study, and this again was impressive with high rates of MRD negativity demonstrated. So overall, the conclusions were that the fixed duration ViPOR regime resulted in high levels of undetectable MRD, complete remissions, and this was seen in high-risk patients as well, both in the frontline and relapsed refractory setting. And it seems to be safe. No DLTs were observed. There weren't any episodes of tumor lysis syndrome. Some patients had to dose attenuate, but it seemed to be a manageable regime. So Certainly intriguing whether this regime has any sort of legs moving forward in terms of genuine development pathway beyond an academic study, I think is debated. But clearly, if you manage a protocol very carefully, you can combine a number of active drugs together in a regime such as this.
Yeah, that is, I think, the most novel agents I've seen paired together. So I do worry about cost, but I'd say the tolerability is better than I would have thought, especially with the cytopenias being a problem. So very interesting. Thank you so much, Dr. Eyre, and to Clinical Care Options and our audience for listening. Thank you.
Yeah, thanks for tuning in.
Thank you very much, Dr. Coombs and Dr. Eyre, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Targeted Therapeutics in CLL and MCL, applying emerging BTK inhibitor therapy data to practice, and to access additional resources associated with this program from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.